Welcome to the deep dive. We're here again, ready to take a whole stack of, expert sources and really unpack what matters most for you. Today, we're getting into something pretty critical but maybe not often talked about: diseases of the descending thoracic aorta. Just think of it as this major highway for your blood running down through your chest. Super important.
Absolutely vital. It carries blood from roughly below your collarbone all the way down towards your abdomen.
And our guide for this exploration comes straight from the experts. We're digging into major clinical guidelines.
That's right. Sources like the European Society for Vascular Surgery, these are the documents that really guide doctors in managing these, frankly, quite serious conditions.
And our job today, well, it's to translate that for you. Pull out the key stuff, the interesting bits from those, let's be honest, pretty dense documents.
Make it understandable, yeah. Whether you're maybe a patient yourself or perhaps a caregiver or just someone who wants to be better informed about this really crucial bit of anatomy.
Exactly. We'll cover the sudden emergencies, the chronic stuff, even some genetic links that might surprise you. Expect some, well, hopefully some vivid descriptions to make it clear.
Okay, so let's ground ourselves first. Where exactly is this descending thoracic aorta?
Yeah, good question. Paint us a picture.
Okay, so imagine your aorta, the body's main blood pipe. It arches up from the heart, right? Then makes a big U-turn downwards.
Okay.
The descending thoracic aorta is that long, straight section running down your chest. It starts just after a big artery branches off to your left arm.
Got it.
And it goes down behind your heart, behind your lungs, punches through that big muscle, the diaphragm, and then it becomes the abdominal aorta. So it's really this core highway running vertically through your torso.
A highway. I like that analogy. And it's built tough, presumably.
Oh, incredibly tough. It's not just a simple tube. The wall has 3 distinct layers. There's the intima, that's the inner lining. Then the media, the middle muscular layer, and the adventitia, the outer layer. Think of it like a really heavy-duty hose or maybe the wall of a tire.
Right, layers for strength.
Exactly. Each layer has to be strong and healthy to handle the constant pressure of blood being pumped through it beat after beat.
And how big is it normally, just to give us a sense of scale?
Yeah, the guidelines give us some numbers. In the middle part of the chest, it's usually somewhere around, say, 2.4 to 2.9 centimeters across.
So roughly an inch or so in diameter.
Pretty much, yeah. Though it can vary a bit, with age and body size.
Okay. And what kind of things can weaken that strong wall? What puts it at risk?
Well, the common things that damage blood vessels elsewhere are often the culprits here, too. The guidelines really point to things that hurt that inner layer, the intima.
Like what?
Smoking is a big one. High blood pressure, definitely. High cholesterol, diabetes. These are all major risk factors mentioned in the sources. They basically cause damage over time, making the wall weaker and, well, more prone to problems.
Right, so that's the sort of gradual damage. Yeah. But you hear about things going wrong very suddenly with the aorta. What are these acute aortic syndromes?
Yeah, this is where things get really serious, really fast. Acute aortic syndromes, it's a group of sudden, often life-threatening conditions affecting the aorta, and they usually cause just, well, terrible pain.
Okay.
And for the descending aorta, the one we're focusing on, the most common one the guidelines discuss is acute type B aortic dissection.
Dissection. What exactly does that mean?
Okay, picture that 3-layered wall again. In a dissection, there's a tear, usually a sudden one, in that inner layer, the intima.
Right.
And because the blood is under such high pressure, it forces its way through that tear and starts splitting the layers of the wall apart, particularly that middle layer.
Wow.
Yeah. It creates a new channel within the wall itself, running alongside the normal path for blood. Doctors call this the false lumen.
False lumen.
While the original proper channel is the true lumen. So going back to your highway analogy, it's like the wall of the highway has suddenly split open and blood is now rushing into the structure of the wall itself, where it absolutely shouldn't be. It puts immense stress on the remaining outer layers.
That sounds incredibly dangerous. Where does that initial tear usually happen?
The guidelines note it often occurs right near the beginning of the descending aorta, just after that artery going to the left arm branches off.
Okay.
And sometimes there's another tear further down where the blood in that false channel can kind of find its way back into the main true channel. Now, doctors classify these. There's a system called the Stanford classification. Type A is different. It involves the aorta closer to the heart, the ascending part, and that's often an immediate surgical emergency.
Right.
We're focused on type B, which starts further down in that descending part running through the chest.
Acute just means it happened recently.
Exactly, within the first 2 weeks. If it's diagnosed later, say between 2 weeks and 3 months, it's called subacute. And if it persists beyond 3 months, then it's considered chronic.
Got it. So who's most at risk for this sudden acute type B dissection?
Well, one factor just jumps off the page in the sources: high blood pressure.
Really? How common?
It's reported in almost 80% of patients with this condition. 80%.
Wow.
Just imagine that constant excessive force hammering away at the artery wall day in, day out. It's a massive stressor.
Makes sense. What else?
Other things mentioned include, while getting older, hardening of the arteries, atherosclerosis, certain heart valve issues, even things like cocaine use, pregnancy, really strenuous physical exertion, or severe emotional stress can be triggers in some cases.
Okay.
But here's something the guidelines really highlight, especially for younger people who experience this: a strong link to genetic connective tissue disorders.
Like Marfan syndrome.
Exactly. Marfan, Loeys-Dietz syndrome, Ehlers-Danlos syndrome. These conditions make the body's connective tissues, including the aorta wall, inherently weaker. The guidelines actually state that about half of patients under 40 with an aortic dissection have one of these conditions.
Half. That's huge.
It is. It really underscores that this isn't solely an issue of aging or lifestyle factors for everyone. And it makes knowing your family history, any history of aneurysms, dissections, incredibly important.
Absolutely. So, okay, what does it feel like if this happens? How would you know?
The classic symptom, and the sources say this occurs in about 80% of cases, is sudden, absolutely excruciating pain.
Where is the pain usually?
Typically in the chest or the back, often right between the shoulder blades. People often use really strong words to describe it, like a tearing or a ripping or stabbing feeling. Just comes on instantly, like a thunderclap.
That sounds unmistakable.
You'd think so, but here's the challenge. The sources stress that symptoms can actually vary a lot, and they can mimic other conditions, which can delay diagnosis.
What other signs might there be?
Well, things like abdominal pain, feeling dizzy, maybe noticing a difference in the pulse strength or blood pressure between your arms or legs. Sometimes, unfortunately, the first signs are related to severe complications like signs of shock, or maybe symptoms suggesting blood flow is cut off to organs, kidneys, or limbs.
Oh.
And what makes it really tricky sometimes, according to the guidelines, is that occasionally there are no symptoms, or the pain isn't that classic severe type, which obviously makes figuring it out much harder.
Yeah, definitely. And you mentioned complicated versus uncomplicated earlier.
Right. That's a really crucial distinction doctors make right away. Complicated means there are already signs of major trouble, like the aorta might be leaking or rupturing, or the dissection is cutting off blood supply to vital organs, or the patient's blood pressure is dangerously low, they're in shock. These complicated cases are far more immediately life-threatening.
Okay, so incredibly serious. If there's a suspicion, the symptoms, the risk factors, how do doctors actually confirm it's a dissection?
Well, the history and the physical exam, listening to the chest, checking blood pressure in both arms, feeling pulses, those are vital first steps. But to actually see the dissection, imaging is absolutely key.
What kind of imaging?
The number one tool highlighted in the guidelines is computed tomographic angiography. You'll often hear it called a CTA scan.
Okay, CTA, what is that?
It's basically a very fast, very detailed X-ray scan. They inject a contrast dye iodine base usually into your vein, and this makes the blood vessels light up really clearly on the scan. The sources call CTA the gold standard for suspected cases, especially if an initial chest X-ray looks abnormal.
Why is it the gold standard?
Because it's quick, it's widely available in most hospitals, and it's incredibly accurate. The guidelines mention near 100% sensitivity and specificity, meaning it's excellent at both finding dissections when they're present and ruling them out when they're not. It gets a Class 1 recommendation, the highest level for this use.
Are there any downsides to CTA?
Yeah, there are trade-offs. It involves exposure to ionizing radiation, which is always a consideration, though the doses are managed. And the contrast dye can be tough on the kidneys, especially for people who already have kidney problems.
So, are there alternatives?
Yes, magnetic resonance imaging, or MRI, is another excellent option mentioned. The big advantage of MRI is no radiation.
Right.
It can be particularly useful for patients who can't have the standard CTA contrast dye due to kidney issues, although sometimes MRI uses a different type of contrast agent. MRI can also be really good for getting very detailed pictures of the aorta wall itself.
Some of the other methods.
The sources briefly mention a couple of others for specific situations. TE, or transesophageal echocardiography, Uses an ultrasound probe passed down the esophagus, your swallowing tube, to get very close-up views of the aorta from the inside, essentially.
Okay.
And IVUS, intravascular ultrasonography, involves threading a tiny ultrasound probe inside the artery itself, usually during a procedure like T-VAR, to get real-time images.
All right. So let's say the diagnosis is confirmed. Acute Type B dissection. What happens next? What's the treatment goal?
The immediate goals are basically to stabilize the patient, prevent the aorta from rupturing, and make sure vital organs are getting enough blood.
And how do they do that? Does it depend on whether it's complicated?
Yes, absolutely. For cases that are initially deemed uncomplicated, meaning no immediate signs of rupture or organ damage, the first line of treatment is typically medical management.
So medications first.
Right. It's all about reducing the stress on that damaged aorta wall. That means aggressively lowering blood pressure. The guidelines suggest aiming for a systolic pressure, the top number, between 100 and 120, and also slowing the heart rate down, usually aiming for below 60 beats per minute.
What kind of drugs do they use?
Beta blockers are very commonly used for both heart rate and blood pressure. Other blood pressure meds might be added as needed. And crucially, controlling that severe pain is also paramount. Persistent pain can actually be a sign that the dissection is getting worse.
Okay, that's for uncomplicated. But what if it is complicated? Or if the medical approach just isn't working?
Then intervention becomes necessary. And here, the guidelines are quite clear. The strongly preferred approach, with a Class 1 recommendation, is T-VAR.
T-VAR. That's Thoracic Endovascular Aortic Repair.
Exactly. It's a minimally invasive technique. Instead of a big open chest surgery, the doctors usually go through a large artery in the groin, the femoral artery.
Okay.
They insert a catheter, a thin tube, and guide it up into the thoracic aorta using X-ray imaging to see where they're going.
And then what?
Through that catheter, they deploy a stent graft. Think of it as a fabric tube reinforced with a metal mesh frame. It's collapsed down inside the catheter.
Right.
They position it very precisely across the site of that initial tear in the inner lining of the aorta. When they deploy it, it expands and seals against the healthy aorta wall above and below the tear.
So it covers the hole, basically.
Exactly. It essentially creates a new, smooth pathway for blood flow within the original true lumen. It redirects the blood away from that tear and the false channel. The idea is to seal off the entry point, relieve the pressure in the false lumen, and hopefully allow it to clot up and maybe even shrink over time. It's like putting a strong reinforcing liner inside that damaged section of the highway.
And this is preferred over traditional surgery.
For complicated acute type B dissections, yes, definitely. The guidelines give T-VAR that top class 1 recommendation as the first-line treatment because studies consistently show it leads to better early survival rates compared to open surgery in this urgent setting.
Is T-VAR ever used for uncomplicated cases?
That's an interesting area. The guidelines suggest it might be considered selectively for some uncomplicated patients. The thinking there is that maybe intervening early could prevent the aorta from enlarging or causing problems down the road. But that's more nuanced and depends on specific patient and dissection features.
And what about the traditional open surgery, opening the chest?
Open repair involves, well, exactly that. A major operation, opening the chest and surgically replacing the damaged section of the aorta with a synthetic graft. While the techniques and outcomes for open surgery have certainly improved, it's still a much bigger, more demanding operation with significantly higher risks of complications, especially when done urgently for an acute dissection.
So generally avoided if possible in the acute phase.
For complicated type B, yes. The guidelines actually give open repair a Class 3 recommendation in that specific situation, which basically means it's generally not recommended or considered potentially harmful as a first choice compared to T-VAR.
That's quite clear. Are there significant risks with T-VAR too, though?
Oh, absolutely. Even minimally invasive procedures have risks. One of the most serious concerns mentioned in the sources is spinal cord ischemia, damage to the blood supply of the spinal cord, which can potentially lead to weakness or even paralysis in the legs.
Wow, how do they manage that risk?
Doctors use various strategies. Things like careful monitoring of nerve function during the procedure, keeping blood pressure within a certain range, sometimes even placing a drain to temporarily remove a small amount of spinal fluid to reduce pressure. Stroke is another potential risk that needs careful management.
Okay, so let's shift gears a bit. What about after the immediate crisis? If someone survives an acute dissection and maybe it doesn't fully heal, becomes chronic after 3 months, what happens then?
Right, the journey definitely doesn't end there. Ongoing management is crucial because even a chronic dissection carries long-term risks. The main worry is that the dissected segment, especially that false lumen, can gradually enlarge or dilate over time.
And if it gets too big?
If it gets too big, the risk of it rupturing becomes much higher, which is obviously a catastrophic event.
So how are these chronic situations managed?
Two key things. Continued long-term medical therapy, especially really good blood pressure control that remains fundamental. And second, regular surveillance with imaging, just keeping a very close eye on the size and shape of the aorta over time.
And when would they consider another intervention for a chronic dissection?
Intervention is generally considered if the patient develops new symptoms that suggest the dissection is progressing or becoming unstable, or, and this is very common, if surveillance imaging shows the aorta is expanding beyond certain size thresholds.
What size are we talking about?
The guidelines mention specific numbers. They suggest considering intervention when the diameter of the descending thoracic aorta reaches somewhere between 56 and 59 millimeters. And they recommend intervention generally if it gets bigger than 60 millimeters, provided the patient is otherwise healthy enough for a procedure. These are Class 2A or 2B recommendations, suggesting it's reasonable or should be considered.
And is that T-VAR again, or open surgery?
For chronic dissection, both T-VAR and open surgery are options. The choice really depends on the individual patient, the exact anatomy of the dissection, how extensive it is, and the expertise available at the hospital.
Okay. What about aneurysms? Are they different from dissections?
Yes, they are different, though sometimes related. A descending thoracic aortic aneurysm, or DTAA, is basically a bulge or ballooning out of the aorta wall in that chest section. It's usually a gradual weakening and stretching, often linked to atherosclerosis or just aging, rather than that sudden tear of a dissection.
But the risk is similar: rupture.
Exactly. The main risk with any aneurysm is that as it gets bigger, the wall gets thinner and weaker, and eventually it could rupture. So, like with chronic dissection, size matters. The guidelines give a Class 1 recommendation, the strongest kind, for intervening on DTAs when they reach a diameter over 55 or 60 millimeters, again, depending on the specifics of the patient.
And the treatment options are similar: T-VAR or open?
Yes, both endovascular, T-VAR, and open surgical repair are used for DTAs as well. Again, the choice is tailored to the patient.
You mentioned something called thoracoabdominal aneurysms, too.
Yes, TAAs. These are particularly complex. They are aneurysms that involve the aorta spanning both the chest, thoracic, and the abdomen. The real challenge here is that this section of the aorta gives off critical branches to the intestines, the kidneys, the liver, the spleen, and importantly, the spinal cord.
So repairing it is much harder.
Much harder. Repairing a TAA, whether open or endovascular, requires very specialized techniques to preserve blood flow to all those vital organs. These are major procedures done at specialized centers. Both require very careful preoperative assessment of the patient's heart, lung, and kidney function.
Makes sense. The guidelines covered some other, perhaps less common conditions affecting this part of the aorta, too.
It did, yes. A few worth mentioning briefly. Ruptured aneurysm, that's the worst case scenario, a true emergency. If it happens, and if the patient's anatomy is suitable, the guidelines strongly favor attempting an endovascular repair, T-VAR, first, if possible, because it's generally much faster and less physiologically stressful than trying to do a massive open surgery on someone who is actively bleeding internally. So, Class 1 recommendation for T-VAR in ruptured cases if the anatomy works.
Okay. What else?
Blunt traumatic aortic injury. This is damage from sudden impact. Think serious car crashes, major falls.
Right.
CTA scanning is crucial for diagnosis here. And again, if the injury pattern is suitable, endovascular repair with a stent graft is often the preferred treatment, especially in younger, otherwise healthy trauma patients. Also gets a Class 1 recommendation in appropriate cases.
What about inflammation?
Good point. Aortitis, or inflammatory diseases of the aorta. Conditions like Takayatsu arteritis or giant cell arteritis, here the wall itself gets inflamed.
What does that do?
It can cause the aorta to narrow stenosis, or it can weaken the wall and lead to aneurysm formation. Treatment usually starts with strong anti-inflammatory medications, often corticosteroids. If the aorta gets too narrow and causes problems, or if an aneurysm develops and gets too large, then surgery or stenting might be needed.
Okay. And something called coarctation.
Yes, coarctation of the aorta. This is a narrowing that someone is born with, a congenital condition. It's usually located right near the beginning of the descending aorta.
If you're born with it, wouldn't it be found in childhood?
Often, yes. But sometimes it's milder and doesn't get diagnosed until adulthood. Maybe someone presents with unusually high blood pressure just in their arms, or they have weaker pulses found in their legs during an exam. MRI is often used to diagnose it. Treatment involves relieving that narrowed section. Traditionally, that was open surgery. But increasingly, especially in older children or adults, endovascular approaches like balloon angioplasty, stretching it open, or placing a stent are used. Though the guidelines note long-term results, like the risk of it narrowing again or aneurysm forming later, are still being closely watched for these newer techniques.
And we keep coming back to genetics.
We do, because it's so important. Conditions like Marfan, Loeys-Dietz, Ehlers-Danlos, even Turner syndrome, the sources really emphasize these make the aorta inherently weaker. People with these syndromes are much more likely to develop aneurysms or dissections, and often at a younger age or when the aorta isn't quite as large as you typically expect trouble in someone without the syndrome.
So genetic testing and family screening seem key.
Absolutely. Genetic counseling, screening other family members, these are strongly recommended if one of these syndromes is suspected. And for women with these conditions, pregnancy carries significantly higher risks for the aorta, needing very careful planning and management with specialists.
Are there any other really rare things mentioned?
Just briefly, the guidelines touch on things like primary aortic tumors, thankfully very rare, usually cancerous and difficult to treat, and something called floating thrombus, basically, a mobile blood clot just sitting in the aorta that could break off and travel downstream, causing a blockage. The best way to treat that is apparently still debated among experts.
Wow. Okay, so across all these conditions, whether it's acute, chronic, aneurysm, trauma, it sounds like once you have a diagnosis or treatment, you're not really done. Surveillance is key.
Is absolutely critical. You said it perfectly. The journey doesn't end. The aorta is dynamic. It can change over time, even years after a successful repair or if something is being managed medically. So regular checkups, primarily with imaging, are essential to catch any changes early.
What changes are they looking for?
Things like, is the aorta getting bigger? Is the dissection flap moving? If someone had T-VAR, is there any sign of blood leaking around the stent graft? They call those endoleaks.
Endoleaks. Are they dangerous?
Some types are, yes. Certain types of endoleaks mean the aneurysm sac might still be under pressure and could still potentially expand or rupture. The guidelines give a Class 1 recommendation for promptly fixing specific types of endoleaks if they're found after T-VAR.
And what imaging do they use for this long-term surveillance?
Mostly the same tools. CT and MRI are the mainstays.
With the same pros and cons we talked about. Radiation with CTA, potential issues with MRI.
Exactly the same trade-offs. CTA gives great detail, but there's the cumulative radiation dose over potentially many years, which is a real concern, especially for younger patients. And the contrast dye can affect kidneys long-term, too. MRI avoids radiation, which is a big plus for lifelong surveillance, but it might not be possible for everyone depending on the type of stent graft they have, and sometimes the images aren't quite as clear for certain things. Chest x-rays can play a role too, sometimes just checking the position of the stent graft.
How often are these scans needed?
It varies, but the guidelines suggest a pattern. Often, it's more frequent early on, maybe at 1 month, 6 months, 12 months after diagnosis or repair. Then, if everything looks stable, the interval might stretch out to yearly or potentially even less often after several stable years. But importantly, the experts lean towards lifelong imaging follow-up after T-VAR that gets a Class 2A recommendation, meaning it should be considered standard practice.
Lifelong surveillance. That really underscores the seriousness and the chronic nature of many of these aortic conditions.
It really does.
Well, this has been an incredibly thorough deep dive. You've really helped us navigate the complexity of these descending thoracic aorta diseases, drawing from those expert guidelines. It's clear there are established ways to diagnose and manage them, but also that it's a really complex field.
It certainly is, and the guidelines themselves are quite open about what they call gaps in evidence.
Meaning things we still don't know for sure.
Exactly. They acknowledge that while we know a lot, there are still areas where more research is needed to pin down the absolute best approach. Things like, the perfect strategy to prevent spinal cord problems in every single case, or exactly what the optimal long-term follow-up schedule should be for every specific condition or repair type. Medicine is always learning, always evolving.
That's a great point. Well, thank you so much for walking us through all of this dense but really vital information today and pulling out these key insights.
My pleasure.
And thank you, our listener, for joining us on this deep dive.
And maybe just one final thought to leave you with. based on everything we discussed. We talked a lot about risk factors you can control, like blood pressure, which is huge, but we also touched on that surprising impact of genetics, especially for younger folks.
Right.
So maybe thinking about and knowing your own family's history when it comes to any kind of aortic issue, aneurysm, dissections, sudden unexplained deaths even, maybe that's even more important for your own health awareness than you previously realized. It's just another powerful reason to stay informed, stay engaged, and keep talking with your doctors.